Could the most dangerous mole on your body be one that shows none of the typical warning signs? Most skin cancer advice in the United States focuses on obvious changes, but we are covering the 5 critical areas you must understand to spot the deadliest skin cancer, melanoma, before it's too late. This video is a deep dive on melanoma and what impact it might have on your longevity. What exactly is melanoma, and why does it matter? Melanoma is a formidable type of skin cancer originating in cells known as melanocytes. These cells are distributed throughout the top layer of our skin, the epidermis, and their primary function is to produce a pigment called melanin. Melanin acts as the body's natural sunscreen, absorbing and dissipating harmful ultraviolet, or UV, radiation, before it can penetrate deeper and damage the DNA within our skin cells. The amount and type of melanin you produce is determined by genetics, which is why skin tones vary so widely. When skin is exposed to UV light from the sun, or artificial sources like tanning beds, melanocytes ramp up melanin production in an attempt to protect the skin, a process we recognize as tanning. However, this process is itself a sign of skin damage. When UV radiation overwhelms these defenses and causes direct damage to the DNA of a melanocyte, it can trigger a cascade of mutations. These mutations can disrupt the cell's normal life cycle, disabling the built-in safety mechanisms that control growth and division. When this happens, a melanocyte can begin to multiply uncontrollably, forming a malignant tumor, which is what we call melanoma. What truly distinguishes melanoma from its more common counterparts, like basal cell and squamous cell carcinoma, is its aggressive nature and its profound capacity to metastasize. This means it can break away from the original tumor site, invade the circulatory or lymphatic systems, and travel to distant parts of the body to form new tumors. It often targets vital organs such as the lungs, liver, bones, or even the brain, making it exceptionally difficult to treat once it has spread. While melanoma accounts for a small fraction of all diagnosed skin cancers, roughly 1%, it is responsible for the overwhelming majority of skin cancer-related deaths precisely because of this invasive potential. This is why early detection is not just important, it is a matter of life and death. For seniors, this concern is amplified significantly. The risk of developing melanoma increases with age, not just because of a lifetime of accumulated sun exposure, but also due to a phenomenon called immunosenescence. This is the natural age-related decline of the immune system's effectiveness. A less vigilant immune system is less capable of identifying and destroying cancerous or precancerous cells, giving melanoma a crucial advantage to establish itself and grow undetected. The median age for a melanoma diagnosis in the United States is 65, placing older adults squarely in the highest risk category. It's also essential to understand the different clinical subtypes of melanoma, as they can present very differently. The most frequently diagnosed form is superficial spreading melanoma. This type tends to grow horizontally across the epidermis for a period of time before it begins its dangerous vertical invasion into the deeper skin layers. It often appears as a flat or slightly raised, discolored patch with the classic irregular borders and color variation. Nodular melanoma, the second most common type, is far more aggressive from the outset. It forgoes the initial horizontal growth phase and grows vertically from the start, invading the dermis quickly. This means it can become dangerous much faster. It typically appears as a firm, elevated bump, which may be dark, but can also be red, pink, or skin-toned, making it easy to misidentify. Lentigo maligna melanoma is a subtype commonly seen in seniors on chronically sun-damaged skin, such as the face, neck, and arms. It begins as a flat, tan or brown spot, similar to a sunspot or liver spot, and can grow slowly for many years before becoming invasive. Its slow evolution can create a false sense of security. Finally, acral lentiginous melanoma is a rarer form that develops on the palms, soles of the feet, or under the nails. It is not strongly linked to sun exposure and is the most common type of melanoma diagnosed in individuals with darker skin tones, a demographic often overlooked in public health messaging about skin cancer. Its location in these non-obvious areas frequently leads to a delayed diagnosis and a poorer prognosis. Understanding these distinctions is critical because what you should be looking for depends heavily on the type of melanoma that might be developing. The telltale signs: how to spot melanoma. Early. Recognizing the early signs of melanoma is the most powerful tool you have in the fight against this disease. The most widely publicized mnemonic for this purpose is the ABCDE rule, a foundational guide for assessing suspicious spots. Let's explore each component in greater detail. A stands for asymmetry. Imagine drawing a line down the center of a mole. In a healthy, benign mole, the two sides would be nearly identical mirror images. A melanoma, however, is often chaotic in its growth, resulting in two halves that look very different from one another in shape and structure. B refers to the border. A normal mole typically has a smooth, well-defined and even border. In contrast, the border of a melanoma is often irregular, with notched, scalloped or poorly defined edges that seem to bleed into the surrounding skin. C is for color. While a benign mole is usually a single uniform shade of brown, a melanoma is often variegated, displaying multiple colors or shades. You might see a mixture of tan, brown and black, or even the appearance of red, white or blue as the lesion evolves. This uneven distribution of color is a significant red flag. D represents diameter. Historically, the guideline has been to watch for moles larger than 6 millimeters, roughly the size of a pencil eraser. While this holds true for many melanomas, it is crucial to remember that they can start much smaller. The most important factor isn't the absolute size, but whether it is growing. This leads to E for evolving, which is arguably the most critical component. A mole that changes in any way, in its size, shape, color, or elevation, demands immediate attention. This also includes the development of new symptoms, such as itching, tenderness, bleeding, or crusting, in a mole that was previously asymptomatic. However, a dangerous oversimplification is to rely solely on the ABCDEs. Many people believe that all skin cancers must look like a dark, irregular mole. But this is a pervasive and dangerous myth. Some of the most aggressive forms defy these rules. This is where the concept of the ugly duckling sign becomes invaluable. This simple rule encourages you to survey your skin and look for any mole that stands out from the others. If you have many moles that look relatively similar, but one looks entirely different in size, shape or color, that ugly duckling is the one that warrants the most suspicion, even if it doesn't meet the strict ABCDE criteria. It's an outlier, and in dermatology, outliers are cause for concern. Moreover, nodular melanoma, which is responsible for a disproportionate number of melanoma deaths due to its rapid vertical growth, often does not fit the ABCDE mold. It frequently presents as a firm, dome-shaped lesion that is symmetrical and uniform in color. It can be black or brown, but often it's pink or reddish, a form known as a melanotic melanoma. Because it lacks pigment, it can be easily mistaken for a benign pimple, an insect bite, a cyst, or another harmless skin growth. The key giveaways for this dangerous subtype are what some call the EFG rule: elevated, firm to the touch, and growing rapidly over a period of weeks to months. Any new, persistent and growing bump on your skin should be considered suspicious until proven otherwise. Beyond these rules, vigilance requires checking every part of your body, not just the sun-exposed areas. Acral lentiginous melanoma, which appears on the palms of the hands and soles of the feet, can initially look like a simple stain or bruise. On the feet, it can be overlooked for months or even years. When it appears under a fingernail or toenail, it is known as subungual melanoma and is often dismissed as a fungal infection or dried blood from an injury. A key difference is that a bruise from trauma will grow out and disappear as the nail grows, whereas a subungual melanoma will remain. A dark streak that widens over time, or is associated with pigment leaking onto the surrounding skin of the cuticle, a finding called Hutchinson's sign, is highly indicative of melanoma. Similarly, mucosal melanoma develops in the mucous membranes lining the mouth, nasal passages, and other areas. The symptoms can be vague, such as a persistent sore that won't heal, unexplained nosebleeds, or a pigmented patch inside the cheek. This makes regular dental and physical exams that include inspection of these areas incredibly important. The ultimate takeaway is that you are the foremost expert on your own skin. A monthly self-exam in a well-lit room with the aid of mirrors is one of the most effective health habits you can adopt. If you notice anything new, changing, or simply unusual, do not wait. Trust your instincts and have it examined by a professional. If you have a spot on your skin that has concerned you, please share your experience in the comments below. Hearing from others in the community can be incredibly reassuring and helpful for everyone watching. The science behind melanoma. Causes and diagnosis explained. The development of melanoma is a complex interplay between environmental factors and genetic predisposition, but the primary environmental culprit is undeniably ultraviolet radiation. UV light, a component of sunlight, is categorized into UVA and UVB rays. UVB rays are shorter and more energetic, penetrating the epidermis and causing direct damage to the DNA within skin cells. This is the type of radiation primarily responsible for sunburn. UVA rays have a longer wavelength, allowing them to penetrate more deeply into the skin's dermal layer. While less likely to cause sunburn, UVA rays generate oxidative stress and free radicals, which cause indirect but equally significant DNA damage. Our cells have sophisticated DNA repair mechanisms designed to correct this damage. However, intense intermittent sun exposure, such as getting a severe blistering sunburn or chronic exposure over many decades, can overwhelm these repair systems. When the damage is too extensive to be fixed, permanent mutations can occur in critical genes that regulate cell growth. One of the most well-known of these is the BRAF gene. A mutation in this gene present in approximately half of all melanomas, acts like a stuck accelerator pedal, instructing the melanocyte to grow and divide relentlessly. While UV exposure is the leading risk factor, a person's individual genetic makeup plays a massive role in determining their susceptibility. Individuals with fair skin, light-colored eyes, and red or blonde hair have less melanin, affording them less innate protection from UV rays. A high number of moles, particularly more than 50, or the presence of atypical moles, known as dysplastic nevi, are also powerful predictors of increased risk. A family history is another critical component. Having a first-degree relative, a parent, child, or sibling with melanoma can increase your own risk by a significant margin. This suggests the inheritance of genes that may compromise DNA repair capabilities or other cellular control mechanisms. Furthermore, a weakened immune system dramatically increases risk. This can be due to medical conditions like HIV, lymphoma, or autoimmune diseases, or from taking immunosuppressive medications following an organ transplant. As we age, the natural decline of our immune system, or immunosenescence, also contributes to this increased risk, making seniors particularly vulnerable. The diagnostic process begins when a patient or a doctor identifies a suspicious lesion. A dermatologist will first examine the spot, often using a dermatoscope. This is a handheld magnifying device with a light source that allows the doctor to see structures within the skin that are not visible to the naked eye, helping to differentiate between benign and malignant features. If melanoma is suspected, a skin biopsy is the definitive next step. It is the only way to confirm a diagnosis. The preferred method for a suspected melanoma is an excisional biopsy, where the entire visible lesion is surgically removed along with a narrow margin of normal-looking skin. This is crucial because it provides the pathologist with the entire tumor for analysis. The tissue is then sent to a laboratory where a dermatopathologist, a specialist in diagnosing skin diseases at a microscopic level, will examine it. The resulting pathology report is the blueprint for treatment. It will confirm the diagnosis and provide several critical pieces of information. The most important is the Breslow thickness, a precise measurement in millimeters of how deep the tumor has penetrated the skin. This is the single strongest predictor of a patient's prognosis. The report will also note if the tumor is ulcerated, meaning the epidermis over the lesion has broken down, which indicates a more aggressive tumor. Finally, the mitotic rate, or how quickly the cancer cells are dividing, may also be reported as another indicator of aggressiveness. This detailed information is then used to stage the cancer using the TNM system, which guides every subsequent treatment decision. From medication to therapy, a guide to treating melanoma. The treatment strategy for melanoma is entirely dictated by its stage at diagnosis. For early-stage disease, such as stage 0, melanoma in situ, or stage 1, where the tumor is thin and localized, surgery is the primary and often curative treatment. The procedure is called a wide local excision. After the initial biopsy has confirmed the diagnosis, the surgeon returns to the site and removes a wider margin of healthy tissue around the biopsy scar. The size of this margin, typically ranging from 1 to 2 centimeters, is determined by the Breslow thickness of the tumor. The goal is to ensure that no stray cancer cells are left behind. For most patients with early-stage melanoma, this procedure is all that is required, followed by a schedule of regular skin surveillance. If the melanoma is thicker or has other high-risk features, the surgeon may also perform a sentinel lymph node biopsy. This is a minimally invasive surgical procedure used to determine if the cancer has begun its journey to other parts of the body. The sentinel node is the very first lymph node that a tumor is likely to drain to. By injecting a special dye or a safe radioactive tracer near the tumor site, the surgeon can identify and remove this specific node for pathological examination. If the sentinel node contains no cancer cells, it is highly probable that the cancer has not spread and no further lymph node surgery is needed. If it does contain cancer cells, the patient is diagnosed with stage 3 melanoma, and additional or adjuvant therapies are typically recommended to reduce the risk of recurrence. When melanoma reaches stage 3 by spreading to the lymph nodes, or stage 4 by metastasizing to distant organs, the treatment paradigm shifts from local control to systemic therapy. These are treatments that circulate throughout the body to find and destroy cancer cells wherever they may be hiding. The past decade has witnessed a breathtaking revolution in the treatment of advanced melanoma, driven primarily by the development of immunotherapy and targeted therapy. Immunotherapy works by reawakening the body's own immune system to fight the cancer. Cancer cells often exploit natural checkpoints on immune cells, which are proteins designed to prevent the immune system from attacking the body's own tissues. By activating these checkpoints, cancer cells effectively put the brakes on the immune response. A class of immunotherapy drugs called checkpoint inhibitors, which target proteins like PD-1 and CTLA-4, work by blocking these signals. This releases the brakes, unleashing the full power of the immune system to recognize and attack the melanoma cells. These treatments have led to long-term, durable remissions in a significant number of patients with advanced disease, something that was almost unheard of with older treatments like chemotherapy. Targeted therapy is a different but equally powerful approach that focuses on the specific genetic makeup of the tumor. As mentioned, about half of all melanomas have a mutation in the BRAF gene. This mutation fuels the cancer's growth. Targeted therapy drugs, known as BRAF inhibitors and MEK inhibitors, are designed to specifically block the signals from this faulty pathway, effectively cutting off the cancer's fuel supply. These oral medications can lead to very rapid and dramatic tumor shrinkage in patients whose tumors carry the specific BRAF mutation. For this reason, all patients diagnosed with advanced melanoma now have their tumor tissue tested for these genetic markers to determine if they are a candidate for this personalized medicine approach. While older treatments like chemotherapy and radiation therapy still have a role in certain situations, such as providing palliative relief from symptoms, they have been largely supplanted by these newer, more effective and often better tolerated therapies. The choice between immunotherapy and targeted therapy, or how to sequence them, is a complex decision made by a medical oncologist based on the specifics of the cancer and the overall health of the patient, often involving enrollment in clinical trials to access the very latest advancements in care. Living well with melanoma. Key lifestyle and diet changes. Receiving a melanoma diagnosis marks the beginning of a lifelong commitment to skin health and vigilance. Beyond medical treatments, Several key lifestyle and dietary changes can support your overall well-being and play a role in managing your health long-term. The absolute cornerstone of this new lifestyle is rigorous and unwavering sun protection. This is not optional. It is a critical component of your follow-up care. A personal history of melanoma dramatically increases your risk for developing another one in the future, as well as other forms of skin cancer. Sun protection must become an automatic, year-round habit. The first line of defense is avoidance and shade. This means limiting your time outdoors during peak sun hours, typically between 10 in the morning and 4 in the afternoon, when UV radiation is at its strongest. When you are outside, actively seek shade from trees, umbrellas, or awnings. The second line of defense is protective clothing. This is often more effective than sunscreen. Opt for long-sleeved shirts, long pants, and a hat with a brim that is at least 3 inches wide to protect your face, ears, and neck. Look for clothing with an ultraviolet protection factor, or UPF, rating of 50 or higher, which means it blocks more than 98% of UV rays. Sunscreen is your third line of defense and should be used generously on any skin that is not covered by clothing. It is essential to choose the right product and use it correctly. Look for a broad-spectrum sunscreen, which means it protects against both UVA and UVB rays, and ensure it has an SPF, or sun protection factor, of at least 30. There are 2 main types of sunscreens: chemical and mineral. Chemical sunscreens work by absorbing UV radiation and converting it into heat, while mineral sunscreens, which contain zinc oxide or titanium dioxide, create a physical barrier that reflects UV rays. Both are effective, and the best one is the one you will use consistently. Application is key. Most people apply far too little sunscreen to achieve the level of protection stated on the label. The recommended amount is about 1 ounce, or a full shot glass, for the entire body. It should be applied at least 15 minutes before sun exposure and must be reapplied every 2 hours, or more frequently after swimming, sweating, or toweling off. Regular skin examinations are also a non-negotiable part of life after melanoma. This involves 2 parts: monthly self-exams at home and regular professional exams with your dermatologist. For your self-exam, use a full-length mirror and a hand mirror in a well-lit room to inspect every inch of your skin, from your scalp to the soles of your feet and in between your toes. Document your skin with photos to help track changes over time. Your professional follow-up schedule will be determined by your doctor based on your stage of diagnosis, but is often every 3 to 6 months for the first few years. While there is no specific anti-melanoma diet, adopting a healthy eating pattern can support your immune system and overall health. Focus on a diet rich in antioxidants, which can help protect cells from damage. This means eating a colorful variety of fruits and vegetables, such as berries, leafy greens, tomatoes, and carrots. Incorporate lean proteins, healthy fats from sources like avocados and nuts, and whole grains. Staying well hydrated is also important. Finally, do not underestimate the power of managing stress. A cancer diagnosis is incredibly stressful, and chronic stress can negatively impact your immune system. Practices like meditation, deep breathing exercises, gentle yoga, or spending time in nature can be powerful tools for promoting mental and emotional well-being, empowering you to live fully and well. If you enjoyed this video, you will probably also like this one. Please subscribe to this channel and let us know in the comments your thoughts. Thanks for watching.